Are individual states, you think, ready with enough equipment, tests, supplies, people to actually do real serious contact tracing to begin doing this?
I think there's two really critical pieces there. One is mapping every single platform that can run these tests. And that's what we've spent the last week doing, to really work with governments and work with governors and mayors to really understand the depth and breadth of equipment that can run these tests in their state and in their cities. And that's been really critical. And then we're marrying that up with CDC. CDC already has about 500 plus people on the ground in many of the states. They will be ensuring that there's people in every state to really support the local governments and the state public health officials to really analyze each one of these gating criteria and determine exactly where they are and what needs to be done.
We're going to talk a little bit more about testing, Dr. Birx, and thank you, by the way, for your service. We really appreciate it. But the contact tracing, though, I've heard estimates that you could need hundreds of thousands of people to adequately do contact tracing. Now we're learning that people may spread this even before they have symptoms. In the pre-symptomatic phase, they could be more contagious. Do we have enough infrastructure to contact trace the way that we need to?
I think that's why the criteria that you can see, the gates that that the federal government has recommended, are fairly strict. And that's to give states really the time to really set up exactly how they're going to contact trace with the CDC in the background as supporting. And I think those two pieces together will really need to move forward over the next few weeks as the states move through and really decrease the number of cases. And again, I want to just start by saying we know mortality is a lagging indicator, and we know that that's going to continue as it did last week into this week.
I mean, this may not be in your purview, but if a state is wanting to hire 1,000 people or 2,000 people to do contact tracing with the public health department and quickly train them and get them to do that, is there money that the federal government will give to the state to do that?
Well, I think in the CARE Act and even the Act for Phase 1, there was funding given to CDC for this very reason, to really strengthen the public health responsiveness at the state level. And that's really going to be critical, both for right now and potential for a reoccurrence in the fall, to make sure we're really ready, because then we're going to have both the combination of flu and COVID. And so we really not only have to have testing and really working closely with the states, but we really have to make sure we can contact trace rapidly.
And Dr. Birx, obviously, people, including yourself and Dr. Fauci, have said testing in the beginning at least was inadequate. As we go forward, if you look at the state core responsibilities, it says that they have to have safe and efficient testing. But we're hearing from states that they don't have the capacity to do this. They need help from the federal government, just in terms of the equipment, for example. Whose responsibility is it now going forward to make sure everyone who needs to be tested can be tested? The states or the federal government?
So we have at the task force level, we have a federal task force that's really working on testing strategy in partnership with the states and local governments. And together, this isn't possible unless we work as a seamless team. So we're working with them to identify all the laboratories, all the things that they need, and they are working very seamlessly to work on getting those things. If you see what FDA has done, just in the last 3 weeks, we've moved from that nasopharyngeal swab to a single polyester swab, and now the FDA is working very closely to see whether cotton Q-tip-like swabs can be utilized. We moved from viral transport media all the way to normal saline. So these kinds of changes have really come to be possible because the FDA has been hearing from the states about what their problems are and looking for alternatives and really doing testing with the commercial labs to see what else can be utilizable. And so I know it's been dynamic. It continues to be a work in progress, but it's really a partnership between the state and the federal government.
But a lot of the states are saying, the governors are saying, we don't have the resources to hire 1,000 or 10,000 people to do contact tracing or to have, very fast testing on hundreds of thousands of people who want to go back to work, and companies want rapid testing to see if employees can go back to work.
Yeah, thank you, Anderson. I think your key statement in that was rapid testing. And I think really figuring out what combination of point of care tests, and we do have some of those now, to medium throughput tests, to really industry level testing where you want to test tens or hundreds of people at once. And what I've discovered in HIV/AIDS is you really have to match the need to the capacity, and really working through that, ensuring all of those are in alignment. And that's part of what states are working through right now, is to really identify where all that equipment is, where the point of care tests are, and how we need to work together to really create that alignment. I know it seems daunting at times, but I've done this all over the world in resource limited settings, and we've been able to really align need with capacity so that you can really respond to what the communities need.
Dr. Birx, just a scenario. Let's say Anderson is going back to work at some point because New York is reopening. I've heard scenarios from public health officials that people might need to get tested every week, even more frequently than that, before they could walk into the building. First of all, could that be the case, that we need to be tested on a regular basis? And again, do states or businesses or whoever would be doing that at this point have the capacity to do that kind of testing?
Well, let's say we had 140 million workers in the United States. There is no disease where we test 140 million workers on a weekly basis. And I think that's why we have to be strategic and smart enough that we combine surveillance opportunities in the community, because the virus doesn't come from nowhere. It has to actually be in the community. And so that's why you have to really have a combination of sentinel surveillance, some early warning systems like the syndromic and the influenza-like illness, combined with testing. Any one piece by itself will not be able to accomplish what we need. And so that's why the focus is on bringing together the talents of the state with the surveillance and the activities that we can really understand, because states have used these for decades, really understanding influenza-like illness and syndromic early alert systems. Using that early alert system with sentinel surveillance and with testing and contact tracing, all three of those have to come together and be designed in a way so that that worker will know that there's not coronavirus in the community. And in addition, if it is, then all of that contact tracing and activity wraps around to really surge both personnel and testing capacity into that particular community.
We've got questions from our viewers. This is from Mo in Pittsford, New York. He sent in a video. Listen.
Both South Korea and China are reporting multiple cases of patients who recovered from the coronavirus, tested negative, then recontacted the virus. If that's the case, what's the implication of it on the ongoing effort to develop vaccines and antibody tests?
Dr. Birx?
This is a really important question. So all of the recent data talks about finding RNA fragments. We don't know if that's full-length RNA. We found that in other diseases, that people will shed, as cells are broken down, partial elements of RNA. Remember, the tests that we're using are highly sensitive. They can find small amounts of RNA. And so I think the jury is really out to understand, is there late shedding in someone who recovers and have antibodies of actually full-length infectious virus? And that's a question that's still outstanding and hasn't been answered in the studies to date, although people are really working on that now and culturing the virus and see if that potential exists.
And then I guess the worst case reason that somebody would have been diagnosed with the virus again is because they got actually reinfected. It wasn't a breakdown of the virus. It wasn't a reactivation. They actually got reinfected. Could that be the case?
Of course, in biology, you never want to say that that's not possible. I mean, certainly coming out of a field where we don't have an effective model of effective immunity, seeing people develop an immune response and recover and have those two linked, at least in the progress of disease we've seen to date, is reassuring to me. But there's always that small perchance person who doesn't make effective antibody, or for another reason doesn't have effective neutrophils or an effective immune response, or points out a little defect that wasn't ever discovered in their genetic response, their immune response to a specific virus. Those outliers always exist, but right now we don't have an evidence that that's a common thing that we see.